Hi, my name is Simone Williams, and I'm doing clinicals at the Veteran Affairs Hospital. Today I'll be talking to you about patient WH. Patient WH is a Caucasian 80-year-old widower. He is currently self-employed as a commercial artist. He works on trucks. Before checking into the hospital, the patient exercised regularly by walking, had normal sleep patterns, had but did not use a cane, and had a normal diet. The patient regularly interacted with his family members and he was active in his church community. He was originally checked into Heartland Hospital where a UTI was treated. Then the patient arrived at the Veteran Affairs Hospital a couple of weeks prior to March 25, 2014. Before arriving at the VA hospital, the patient fell on his back, and his chief complaint was back pain, and it navigated down to his hips and legs. During the stay, the patient was exhibiting some abdominal pain that was treated with medications that caused his abdomen to change colors and appear bruised, which in other cases would be considered abnormal. But under the circumstances, the bruising of the stomach was expected and therefore was not further reviewed. Although the patient's chief complaint was back and abdominal pain, his diagnosis was debility. The patient did not have any past chronic illnesses or illnesses in general besides minor colds and the flu. The patient's vaccines were all up to date. The patient is allergic to penicillin, which was taken into consideration when giving him medications, although penicillin was not necessary. The patient had 2 prior surgeries, which were getting his appendix and his tonsils removed. The patient's current blood pressure is 134/94, his respiratory rate is 18, and his pulse is 76. The patient's current medications include atenolol, a beta blocker that prevents stress hormones from affecting the heart, lisinopril, nifedipine, which is a calcium channel blocker that closes the calcium channels in the heart and ultimately reduces the pressure in the heart by causing arterial dilation, and multivitamins. Atenolol, lisinopril, and nifedipine are used for treating high blood pressure, angina, acute myocardial infarctions, and other cardiovascular issues. The side effects of atenolol were cold extremities, depression, confusion, and difficulty speaking and hearing. None of those side effects were exhibited by the patient. The side effects of lisinopril were jaundice, fatigue, fainting, and tightness in the chest, which were not exhibited in the patient. But abdominal pain was noted in the patient's interview. The side effects of nifedipine were headaches, weight gain, and a shortness of breath, which were other side effects that were not noticed when interacting with the patient. The multivitamins provided gave the patient nutrients that he would not be able to receive due to a loss of appetite. Patient WH was given 12.5 milligrams of atenolol once a day by mouth, 20 milligrams of lisinopril once a day by mouth, 30 milligrams of nifedipine once a day by mouth, and 1 multivitamin a day. Aside from the medication, the patient was in rehabilitation in order to help his back pain. When talking to the patient about his view on his own health, he said that he was fairly healthy and he feels healthy overall. The patient said that he did not experience any weight loss, fevers, chills, night sweats, or heat or cold intolerances. The patient did not have any fatigue that interfered with his usual activities. The patient did not have trouble with headaches, dizziness, fainting at the moment, and the patient did not have any changes in vision, although he had cataracts removed a year ago. He has been to the optometrist a year ago when he got his cataracts removed. The patient did not have any changes in hearing, but he did complain of itching ears, which started 6 months ago. His last dental exam was March 25, 2014. The patient did not have any voice hoarseness or a sore throat, although he said he had trouble swallowing pills. The patient had tenderness in his back due to the fall, but he did not have tenderness anywhere else at the moment. The first pertinent system was the GI tract because he was experiencing abdominal pain while in the hospital. When assessing the abdomen, there were no abnormal findings. There were normal intermittent bowel sounds, and the patient said he was not experiencing any changes in bowel movements or any changes in color regarding his bowel movements. He did not have a problem with indigestion or heartburn. The patient's appetite was the same, and he did not feel nauseated after eating. The needles the doctors administered in his abdomen caused his stomach to look bruised, but that was the side effects of the medication, so it was considered a normal finding. The second pertinent assessment was performed in the musculoskeletal assessment because patient WH was experiencing some movement issues due to him falling on his back. The patient said that he was having pain in his hips, legs, and knees because the pain from his back radiated down to his lower extremities. Although he was experiencing pain, he barely had any limitations in his range of motion because he was still able to perform tasks, and he walked and exercised at the hospital regularly. He checked into the hospital immediately after the fall because the pain was unbearable, so his ability to do ADLs was unknown since he hadn't been home. Patient WH felt a little stiffness in his back, and he had minor arthritis issues. An assessment that was not performed on the patient but was still important was the peripheral vascular assessment because his ability to move his joints was inhibited by minor limitations and feelings of pain. During the assessment, he said that he had pain in his legs, thighs, and hips. Fortunately, he did not have edema, coolness, hair loss, history of blood clots in his legs, or varicose veins. According to Roberta Henderson, patient WH was most likely experiencing acute and subacute pain due to his back injury. Patients with back pain frequently have issues that progress to chronic pain and interfere with his or her ability to perform ADLs, such as dressing, lifting, walking, working, and he or she may have impaired functioning. Doing the PV assessment related to patient WH's functioning and his limitations of his physical condition. During the patient interview, patient WH did not show any signs of neurological issues. After the interview, the patient's nurse mentioned that he had been showing signs of sundowning for the past couple of days. She said that the patient seemed completely intact during the day but experienced confusion during the nighttime, which was characterized by his wandering around the hospital thinking he was still being treated for a UTI at Harlan Hospital. Fortunately, the patient interview happened during the daytime, which most likely means all the information provided by the patient was true and not made up. According to Paul Kim, Coralie Lewis, Sunanda Murali, and Rajesh Tampi, sundowning characteristics are also exhibited in dementia, delirium, and sleep disturbances, but the main difference is that the symptoms happen especially during evening hours. Having forms of dementia such as Alzheimer's or Parkinson's disease is associated with neurological problems, which is why patient WH would have been tested neurologically if his sundowning was more pronounced. During the assessment, he mentioned that he was not experiencing any cardiovascular issues or chest pain, but reviewing his medications, atenolol, nifedipine, and lisinopril, showed that he may have been having chest issues prior to the assessment, and the medications were the reason he was not having chest pain at the moment.